So we have a great faculty today, Dr. Lyudmila Bazhenova from the UC San Diego Moores Cancer Center in San Diego, and Dr. Corey Langer from the Aberson Cancer Center in Philadelphia. And back with us is Sunil Gandhi from the Florida Cancer Specialist at Lecanto, Florida. So we're going to talk about HER2, RET, ALK, and ROS1, but I just want to take a breath first before we get into that and ask some sort of pan-targeted questions. So the first is, we talked this morning, of course, about adjuvant osimertinib. We have adjuvant RET with alectinib out there. It's, we're about to see at ASCO adjuvant, I'm sorry, did I say RET? ALK with alectinib. We're about to see adjuvant RET at, I think is that a plenary? Yeah, at ASCO. So I guess, Corey, one question would be, do we need to do a trial for every one of these, and are there targets right now that you would like to or even are using in the adjuvant setting? And also the locally advanced, there, of course, EGFR, RET, again, what do you do with these patients, locally advanced, non-surgical as well, outside of the known approved indications?
I used to be pretty ironclad about not doing approaches that hadn't been vetted already by phase 3 trials. I'm loosening those standards. I think, particularly since we're going to see data at ASCO on selpercatinib and RET, we already have data for ALK and EGFR. It's not hard to extrapolate then to the ROS1 drugs, particularly the more modern drugs, for which we do not yet have phase 3 data. In the locally advanced setting, the stakes are even higher. These patients are much higher risk for further progression, usually within a year or two. The LAURA approach gives osimertinib indefinitely. I'm not sure that's the optimal time period. I certainly would have very little trouble extrapolating that to ALK-positive patients. Again, we have to balance the benefits with the toxicities. Osimertinib and alectinib are relatively non-toxic compared to many of the other TKIs, so it becomes a bit harder, I think, from the patient's standpoint, from their quality of life, to discuss all this, and it really requires shared treatment decision-making.
So, Luda, what's your take on this, and how about adjuvant zongertinib off the label?
Yeah, it's an excellent question. And I think when one tries to answer the question, I'd like to frame it in classes, right? So we have tyrosine kinase inhibitors, which are very effective and minimally toxic. And this is osimertinib, alectinib, selpercatinib. I would add NTRK inhibitors there as well. And I think here it's easy for me to extrapolate, since we now have 3 positive studies and toxicities are manageable. Then we have a second classes of drug, which is your MET exon 14 skipping drug, your BRAF V600E drugs, where the efficacy is almost there, not as high as osimertinib, but the toxicity is definitely much worse. And I think here, I definitely want to see a randomized clinical trial in an adjuvant setting. And then the third one, which is even more difficult, where you see the KRAS, which is a GTPases, not ATPases. So the activity is way lower than osimertinib and ALK inhibitors. And I think here I definitely want to see a clinical trial.
Before Corey comments, Sunil, I'm curious whether or not I assume all your patients now are getting NGS, even in the post-op setting. Have you seen patients with some of these other targetable lesions and been tempted to use it in the adjuvant setting?
Adjuvant setting, I had one patient who I tried for ALK. The data was out there and I could use in one case. But that was one case and he's doing well. So a question came back, how long to give it? So I said, 3 years and we will decide. That's where I have left it right now. It's just 1 year.
So, Corey?
There's 2 unanswered questions. Do we still need platinum in this setting, which is until now been our standard approach? In Alina, the platinum wasn't used in the investigational arm, as you see shortly, whereas it was an option in both the Libretto trial and in the ADORA trials for RET and EGFR. Second issue is the duration of therapy, as you pointed out. We have no clue. ADORA was, osimertinib was given for 3 years, and Alina alectinib was given for 2 years. I'm not even sure how long selpercatinib was given Libretto. Finally, for BRAF, MET, and KRAS, immunotherapy and chemo work fairly well in these populations. And at least for now, that would be my preferential approach, and I think you agree, Lou.
Yeah.
Sunil?
I have one question when you mentioned BRAF. 2 weeks ago, I saw a lady, 49-year-old patient with metastatic BRAF positive, and refused to take any BRAF medicine because she read on internet that all those nausea, vomiting, and other side effects. And was very adamant. I tried my best. And so I put her on standard treatment from the statement you made. That's what I read. Is that reasonable or I was unreasonable? I just gave it in chemo and immunotherapy,
I think it's reasonable. I think when we discuss things with the patient, it is a truly shared decision-making. I think our job as a physician is to educate. And looking at, I think I'm into the targeted therapy camp because even though we think immunotherapy works for the MET exon 14 skipping and BRAF, but we never had a prospective study where we reported how the immunotherapy and chemotherapy works for those patients. So if I'm talking to the patients, I actually don't know what numbers I'm going to give them because those patients were included but never reported in the prospective studies. And the only thing we have is basically retrospective analysis. And also, I'm a little bit, I think, impressed with the encorafenib binimetamine data. The overall survival was just reported within the last year, and the numbers are really spectacular. So I tend to try to convince patients to go for targeted therapy. There are always dose reductions, but at the end, it's not us. It's the patient who makes the decision.
So another sort of pan-target issue, and Corey, you kind of alluded to this, but maybe elaborate a little bit more, is when do we not use IOs in people with targetable mutations? I think we know a lot about EGFR and ALK. I'm not sure beyond that.
I think I would extend our experience with EGFR and ALK to ROS and RET for sure. Those are the fusions where the response rates are phenomenal with targeted agents. In metastatic disease, for either BRAF, MET, or KRAS, I personally would have equipoise looking at a sequencing trial, comparing the TKIs to immunotherapy and chemo, and then vice versa, using the opposite approach for salvage. Locally advanced, again, the toxicities are formidable, and remember, the IOs and chemo do work in those particular more aggressive mutations where our responses with the TKIs aren't quite as impressive as they are with the ALK inhibitors or EGFR inhibitors.
So, Luda, you're going to talk about one of my favorite topics of the past year, which is TKD mutations and lung cancer. What an incredible story, which incidentally, nobody outside of lung has heard about. None of the other investigators. We brought it up at SGO. We bring it up in GI. Nobody's heard about this incredible story that you're about to hear right now. But before you get into that, Luda, again, what about in these TKD mutant, HER2 mutant IOs? Are you going to use durvalumab? Are you going to use zongertinib? Would you use adjuvant zongertinib?
I would not use immunotherapy. I'm in Corey's camp. To mutations that he mentioned, I would add HER2 mutation there as well. Based on immunotarget study by Mazeris, the response rate in second line to immunotherapy for those patients was 0%. So this is going to be one of those. And I think the question that you're asking is an excellent question. I am very tempted to use zongertinib for those patients. The challenge is insurance approval because it's not approved, so it's hard to get.
Would you say, I like to joke around and say zongertinib is the new osimertinib?
Yeah, I would. It's a fairly active drug. Has toxicities, but certainly it's, I think, a level above what we used to have for the HER2 mutant non-small cell lung cancer.
All right, let's talk a little bit about HER2 and RET.
All right, here are my disclosures. So HER2 alterations. In lung cancer, HER2 can be altered three ways. You can have protein overexpression, which is seen in approximately 60% of the patients. You can have amplification, which is seen in approximately 2 to 6% of the patients, and mutations, which are seen in approximately 1 to 5% of the patients. When you look at mutations in lung cancer, you can divide mutations in a TKD mutations. Majority of those mutations are exon 20 insertion, and the most common one is so-called YVMA insertion, which will become important in a second. And we also have other rare TKD mutations, such as L755P, and other mutations in exon 19. Then we have trans and juxtamembrane domain mutations seen in approximately 5 to 10% of the patients. And then we have an extracellular domain mutation seen in approximately 10 to 20% of patients. Very important to highlight that depending on where your cancer started, the type of HER2 mutation differs. In non-small cell lung cancer, majority of those mutations are mutations in exon 20. In breast, majority of those mutations are mutation in exon 19, and in colon, majority of those mutations are extracellular mutation. And even if you look at exon 20 mutations, the mutations are differ in non-small cell lung cancer and breast cancer. So we have 2 FDA-approved agents for patients with HER2 mutation and rearrangement. So first is trastuzumab deruxtecan, which is approved for HER2 mutation after failure of platinum doublet, and HER2 3+ overexpression after failure of platinum doublet. And then we have 2 tyrosine kinase inhibitors, cevabertinib and zengertinib. So let's start first with trastuzumab deruxtecan. Trastuzumab deruxtecan is an anti-HER2 IgG1 monoclonal antibody, topoisomerase inhibitor payload, cleavable linker, and DAR, which is a drug-to-antibody ratio of 8. So first, we looked at the efficacy of TDXD in DESTINY-Lung01. So very respectable response rate of 55%, median PFS of 8.2 months, median OS of 70.8 months, and addition of amplification on top of the mutation didn't seem to make a difference, and the prior exposure to the tyrosine kinase inhibitor, the old tyrosine kinase inhibitor, not the new one, did not seem to make a difference. The problem we had at that time that about 26% of patients in DESTINY-Lung01, which used 6.4 mg per kg dose, had interstitial lung disease, and there were cases of fatal interstitial lung disease. So then the next study that was done is a DESTINY-Lung02, which compared 2 doses, 5.4 mg per kg and 6.4 mg per kg, and the primary endpoint was confirmed overall response rate. As you see in the table on the right side of the slide, the overall response was actually higher numerically in 6.4 mg per kg, as well as progression-free survival was higher in 6.4 mg per kg. But rate of interstitial lung disease went from 28%, which is very similar to what we see in the Lung DESTINY-01, to about 12%. So the FDA approval for TDXD in HER2 mutant lung cancer is at 5.4 mg per kg, similar to breast cancer, but different from gastric cancer, where approval is at 6.4 mg per kg. So another important thing, as our patients with mutations live longer, having ability to protect the CNS is actually quite important. And initially, when we were looking at antibody drug conjugates, everybody had a concern that maybe those drugs do not get into the CNS. And as a matter of fact, they do. So this is the combined analysis from DESTINY-Lung01 and DESTINY-Lung02, and I'd like to put your attention to the last column, combined group without prior treatment. And there, intracranial overall response rate was 41%, duration of response was 6.8 months, and time to progression-free survival, intracranial progression-free survival was 5.6 months.
So before you go on, just a couple questions about TDXD. First, Corey, Luda was referring to the CNS activity. We saw this in breast cancer. Initially, they used a TKI tucatinib, and then TDXD. They started to see these great responses in the brain. Have you observed that? And what do you think is going on? We had this whole argument about blood-brain barrier and all.
You wouldn't think an ADC could get into the brain, but obviously the effects are there. This is not unusual. You go back to original chemotherapy and small cell, etoposide, platinum, we saw responses in the brain. The newer drugs, which I imagine you'll get to in more details on Gertner, may be superior in that regard. In fact, they do appear to be superior, and they cover some of the non-TKD mutations. So I think in short order, as we get used to this, TDXD may be used after zongertinib, and we'll probably see combination trials as well.
So, Luda, I'm curious right now where you integrate TDXD in a patient who's HER2 overexpressed, HER2 3+. Will you use it first line, second line? When do you use it?
For the overexpressors, my usage is in second line because the studies were done post-platinum doublet. The efficacy of TDXD in overexpressing patients is not as high as in a mutant patient, and so I still believe that chemotherapy platinum doublet. I actually use platinum doublet plus sometimes bevacizumab for HER2 mutant, not anymore because we now have a zongertinib approved, but before we had zongertinib first line, my first line treatment was chemo plus beva. For those patients with HER2 overexpression, my first line is chemo IO or IO by itself, depending on the PD-L1 expression.
So, Corey, I'm curious, always curious once we get outside breast cancer, and I'm curious with Sunil's experience when I ask people about acute GI toxicity, sort of GI chemo-like toxicity that you see with TDXD, what you do to try to prevent it, and of course, how do you screen for ILD? What do you do with patients who start out with baseline, respiratory symptoms, COPD, et cetera?
So I'm very leery of using this drug in people with pre-existing interstitial lung disease or already have fairly significant respiratory compromise. On the other hand, it's lung cancer. Most of our patients have some sort of respiratory compromise. And in terms of screening, we're usually getting scans every 6 to 9 weeks, so it's not a matter of ignoring the lung. Because of that concern, I've been very reluctant to use TDXD frontline. It's usually my second-line agent in this setting. And there is, in fact, an ongoing phase 3, I think it's Destiny 4, that is directly comparing 189 pemcarbo-pembro to TDXD in this setting. I don't know how well accrued it is. At the end of the day, this is chemo 2.0. These are very toxic chemo payloads that replicate all the chemotoxicities we've seen. So in some patients, I'll use GCSF prophylaxis, aggressive anti-chemo regimens. You've really got to think chemo when you're giving these drugs, particularly to a more vulnerable population. The lung cancer population, as far as I'm concerned, is generally older and sicker than the breast cancer population.
Sunil, I'm kind of curious, and maybe you have more experience with breast cancer, but what you use in terms of anti-emesis? I've heard a lot of people using olanzapine.
We use olanzapine very frequently on those cases. Particularly, my experience is mainly in breast cancer, but I've used in colon cancers too. And thing is that it works very well. If you work with the patient and sometimes reduction on the dose, nausea is manageable. I haven't stopped one patient TDXD just because of nausea.
So, Luda, another big controversy in breast cancer. We actually saw some data. This is the last meeting. They're always trying. They say we want to diagnose it at grade 1 when they're asymptomatic. And the question comes up: what about somebody who has grade 1? Then it resolves. Would you retreat? They're doing that in breast cancer. It seems like that works. Is that something you would consider in lung cancer?
For grade 1, I will. So, as you remember, grade 1. Pneumonitis is patient has no symptoms and you found it on a CT scan. So patient is asymptomatic. In Destiny Lung 01, the clinical trial was actually allowing us to retreat patient with grade 1 if radiographic abnormalities resolved within 28 days. And I'll tell you, radiographic abnormalities do not resolve within 28 days. So we've never tested the retreatment on the trial in a good enough number of patients. So for grade 1, I could retreat. I was actually a little bit more open to the retreatment before we had zongertinib and cevabertinib. Now I have other drugs that I can use instead.
Of course, not necessarily if they're overexpressed or if they don't have a TKD mutation. Let's talk about these TKIs. Interesting that you have cevabertinib above zongertinib. I thought it would have been the reverse because I keep hearing that zongertinib is better tolerated, but you tell me.
There is no rhyme or reason how I put. I just had a cevabertinib paper downloaded first, so I started with that. So cevabertinib and zongertinib are tyrosine kinase inhibitors that have activities in patients with HER2 mutation. They're a slightly different drug, and if we have time, we could discuss about resistant mutations to those drugs because they're actually slightly different. So both studies looked at 3 different patient populations, and I want to start walking you through from the right side of the slide. So the treatment-naive patients who did not receive any therapy, very high overall response rate of 71% in cevabertinib, 76% in zangertinib. Responses were durable at 11 to 15 month, and progression-free survival, we do not yet have that data for cevabertinib, but in zangertinib, the PFS is 14.4 months. Then moving to the middle part of the slide, cohort E in Seva and cohort 5 in zangertinib, prior exposure to HER2 ADCs, and you can clearly see that response rate is not as high as in treatment-naive patients. Neither is duration of response or progression-free survival. And the third one is a cohort D, which is patients who have had platinum doublet first, but they did not receive any type of HER2 therapy, neither ADC nor TKI. And here we see that the response rate is somewhat similar to the treatment-naive patients. The PFS is a little bit less, and duration of response is a little bit shorter as well. So those 2 medications are different, I think, in adverse event profile. And in cevabertinib, we clearly see more GI toxicity, more diarrhea, more EGFR toxicity, more rash, more paronychia, and compare that with zangertinib, where the incidence of all-grade diarrhea is 54 compared to the 86% in cross-trial comparisons. There is also lower incidence of rash, same incidence of transaminitis, and same incidence of the other side effects. So initially, when I first started discussing the type of mutations, I highlighted the fact that you can have an exon 20 insertions, that YVMA, you can have TKD mutations other than YVMA, and we have a non-TKD mutations. And that does seem to make a difference. So if you compare TKD mutation on the left side of the slide and YVMA mutation kind of in the middle, you can see that the YVMA mutation have a slightly response rate. Of course, it's a subgroup analysis, and definitely longer median progression-free survival. Then if you look at the other TKD mutation on the right side of the slide, they didn't reported the overall response rate, but you can clearly see from that waterfall plot that this is not going to be 70%. This is 50, 55%, and the median progression-free survival is shorter. And then when you look at the non-TKD mutation, there is only 7 patients, but clearly the response rate is not even 50. So the type of the mutation matters. So YVMA do the best. The other TKD, not YVMA, do the second best, and non-TKD mutations do the worst. Same data in zangertinib. So the cohort 3 looked at non-TKD mutation, and here the response rate was 30%, and on the last side of the slide, I put the very similar patient population for the TKD mutation, where the response rate was 71%. So the second thing we want to highlight is the CNS efficacy. So I shared the data with TDXD, and now I'm sharing the data with zangertinib. And you can see here that zangertinib definitely have a CNS activity, looking at any line 120 milligrams and first line 120 milligrams. And you can see that overall response rate, intracranial objective response, is around 50%. So the drug does have CNS activity. And so now moving away from the mutation into overexpression, and here we have 2 studies, DESTINY-Lung01 and DESTINY-Lung03, small number of patients, 41 and 33, but you can see the response rates are there. They're definitely not as high as the response rate of TDXD in EGFR mutant patients, which was 55%, and median progression-free survival is shorter, and median overall survival is also shorter. I'm not showing that data, but if you compare 2+ and 3+, the response rate in 2+ is definitely lower. The response rate in 3+, and the current FDA approval is only for the overexpressors at 3+. So something that Corey mentioned, so ongoing first-line trials with those drugs. So we have BEAMIAN Lung 2, which compares zangertinib at 150 20 milligrams, and a physician's choice standard of care, which is either platinum doublet or platinum doublet plus immunotherapy. Then we have a SOHO-02, which is randomizes cevabertinib to platinum doublet plus IO, and then we have a Destiny Lung 01, which first line randomizes patients to TDXD versus platinum doublet plus immunotherapy. And so in summary, for HER2 patients, HER2 mutations and HER2 overexpressions are targetable. Therefore, it's important to test. We have 3 FDA agents approved: cevabertinib, zangertinib, trastuzumab deruxtecan. We have CNS activity confirmation with zangertinib and TDXD. Cevabertinib yet to report their CNS activity, but they do have a cohort in their study studying that. We have several unanswered questions. I showed you there that mutation does matter. How do we sequence TKI and ADC? What is the longer studies of a CNS activity with a longer follow-up? How durable is it? And then another question, if you try to extrapolate from, let's say, first-line EGFR classical mutations, what if we add chemotherapy to the tyrosine kinase inhibitors? Could you have a better efficacy data? And at this point, there are no studies like that. So my next task is to go in RET, rearranged non-small cell lung cancer, which is a little bit shorter discussion. So RET can be altered in 2 ways. You can have a point mutation, which is primarily seen in medullary thyroid cancer, and you can see fusions, which are mainly seen in papillary thyroid cancer and non-small cell lung cancer. In lung cancer, our most common partner is KIF5B. Other partners are CCDC6 and COA4. The RET rearrangements usually do not occur concurrently with alteration with other oncogenic drivers, and it's about 1% to 2% of patients with lung cancer. We have 2 selective inhibitors, selpercatinib and pralsetinib, and here I put all the data in one slide. So we first start with a treatment-naive population. Confirmed IRC overall response rate is 84%, in selpercatinib 78%, in pralsetinib responses are durable, and then the median progression-free survival is also pretty respectable. And then in platinum pretreated patients, which is kind of an old setting, my pattern is to use those drugs first line, but this is kind of for historical interest. And I think the reason why it's important for the historical interest, because both selpercatinib as well as pralsetinib do have intracranial activities with intracranial overall response rate of 85% and 56% respectively. And responses do appear to be durable as well, and median progression-free survival is pretty long. So this is the confirmation of CNS activities for selpercatinib and pralsetinib. As I mentioned before, high overall response rate and several patients with intracranial complete responses. Adverse events, there are different drugs. So pralsetinib causes more leukopenia and neutropenia, and then selpercatinib does not have those side effects. There is a very unusual side effects of selpercatinib, which is almost like an allergy, where they get the febrile fevers, transaminitis, drop in accounts, and that's managed by drug holding, and then you can actually re-challenge. So what do we know in first line? So we have a Libretta 431, which randomized patients to treatment-naive patients, stage 4, randomized to selpercatinib versus platinum doublet plus minus pembrolizumab. Selpercatinib was a winner in overall response rate of 84 versus 65 with chemo, duration of response 24 versus 11.5 with chemo, and PFS 24.8 versus 11.2 with chemo and pembrolizumab. This is something that you mentioned. It's going to be a plenary session at ASCO, looking at adjuvant settings, so patients who had both definitive radiation or surgery randomly assigned 1-to-1 to either selpercatinib or a placebo, and we know that we have a press release that the study is positive, and full data is going to be available to us in about 1.5 months as a plenary session in ASCO. And so in summary, RET fusions are also targetable alteration. In lung cancer, we have two tyrosine kinase inhibitors, pralsetinib and selpercatinib. Both have very good extracranial and intracranial activity. And we have several drugs in development, although pretty early, looking at RET inhibitor resistance.
So, question to Corey: choice of a RET inhibitor, and also your experience and what the data shows in terms of tolerability, contrasting the two.
They're practically interchangeable, to be honest. I've used selpercatinib probably preferentially simply because it was approved first. So, the first, fabulous, I won't say what the other F is, but when it comes to drug development. But it's really, fortunately, I have the benefit of having a dedicated thoracic oncology pharmacist working with me, who looks at all the other drugs that the patients are on, as well as their comorbidities, and helps advise me on drug-drug interaction, which one of the two is safest. And frankly, that's where I make my decision. Anecdotally, I've had 2 patients on selpercatinib develop chylous
I was just going to ask you about that. I thought I was forgetting the wrong thing. Chylous effusion.
Of course, we thought, my goodness, they had progression. We tapped it, milky fluid came out, stopped the selpercatinib, repeated paracentesis, switched them to pralsetinib. The ascites did not recur.
Interesting. Have you seen that too?
I've seen it, and I think very important statement that Corey made is, we thought this is progression, which is a natural thought, right? So if I have a patient with lung cancer who developed pleural effusion, this is progression. So if your patient's on selpercatinib, very, very important to make sure you tap it and do not assume that this is progression, because otherwise you will be taking patient off the drug. And I think Jessica Lean also has a case of very similar to yours, where the patient had a chylous effusion, stopped selpercatinib, drained it, and then restarted on pralsetinib, and that didn't happen again.
Such a weird toxicity. What do you think the mechanism is?
I don't think we know.
So strange.
Haven't a clue. But I want to reemphasize, it's important to interrogate these patients.
Great point.
Radiologists will say progressive disease. You have to look at your own films, and B, get biopsies and cytologies. You can't assume any of these are disease progression.
That's got to be a big surprise when you pick a needle in and pull out milk.
I got an urgent phone call from IR folks when that happened.
And then another thing to come out, because the natural etiology of chylous effusion is thoracic duct thing. So don't send them to CT surgeon. This is not a thoracic duct injury. This is the drug. So save patient a visit.
I've been meaning to ask you still doing poetry?
Yes.
There's a poet right here.
Some medical poetry, not much.
Just medical poetry. All right, Alkin Ross 1.
Okay. This is a similarly exciting area. Lots of new drugs coming out. My disclosures. ALK in brief. This is probably the third most common oncogenic driver in lung cancer after KRAS and EGFR, about 5 to 7% of all non-small cell. It's imperative you test patients, all adenocarcinoma, regardless of smoking history, all never or former remote smokers, regardless of histology, for the oncogenes, for mutations and fusions. And in our practice, we do both tissue and blood. 2 shots on goal. We know that the ALK TKIs work quite nicely with alectinib shown in the bottom left corner. We're seeing median survivals now approaching 7 years. Remember, this is metastatic lung cancer. IOs do not work well here, and Luda actually alluded to that earlier with Mazaris series. When we get to ALK specifically, these are younger patients. Their median age is in the 50s versus about 70 for the rest of lung cancer. Most are never or light smokers. 70%, in fact, have never smoked. By and large, they have advanced disease at presentation, often multiple lesions, often quite symptomatic, pleural pericardial effusions, a very high propensity for CNS metastasis, probably the highest in our population, and without TKIs, a poor prognosis. We've seen data now in the adjuvant setting. This is the ALENA trial to which we alluded to earlier, comparing alectinib directly to platinum-based chemotherapy, the latter given for standard 4 cycles in stage 1B through 3A, ALK-positive non-small cell. The alectinib stopped at 2 years. Note the investigational arm did not feature platinum-based treatment. This is the updates. Disease-free survival looking quite promising. A hazard ratio here is under 0.40 for both the entire cohort shown on the right and then the stage 2 and 3A cohort. You're seeing a 30% absolute improvement in disease-free survival at 4 years. And on the forest plots, a benefit across the board, regardless of age, race, performance status, tobacco history, stage, or nodal involvement. Of further note, CNS protection is key. At 4 years, 90% on the alectinib arm free from CNS progression compared to 76% in the chemo group. Again, an astounding hazard ratio of 0.37. 2 questions. We don't know whether to use platinum in this group. The data are so overwhelming, you wonder whether you need it. For the same token, we don't know whether it's necessary in the RET population or in the EGFR population. These are a couple of other trials. Nautica is looking at perioperative or neoadjuvant alectinib in resectable stage 1B through 3A. It's part of a larger series, including many other oncogene fusions. And Horizon is basically LAURA in the ALK-positive population. So taking folks with locally advanced, unresectable stage 3 after chemoradiation, and actually comparing alectinib to durvalumab. I would not use durvalumab in either ALK or EGFR population. When it comes to advanced or metastatic disease, of the evolution of drugs over the last 15 years, we started out with crizotinib, which is really of historic interest. Then came ceritinib, which was highly active, rescued patients who had disease progression on crizotinib, but incredibly toxic, particularly GI toxicity. Then alectinib, brigatinib, and more recently lorlatinib and ensartinib, with the approvals of the latter two in frontline in the last 5 years. Very busy chart, basically summarizing all the phase 3 trials with the newer second and third generation agents essentially beating up on crizotinib with major improvements in PFS. We're seeing not merely a mild or moderate improvement, we're seeing 2-3-fold increase in progression-free survival for each of these drugs, and in the case of lorlatinib, a 6-fold improvement. These benefits are seen across the board with or without brain metastases. Response rates hover in the 75-85% range, again, numerically higher than we would see with crizotinib alone. This was from Jessica Lynn's commentary, her discussion 2 years ago at ASCO after the lung plenary session, looking at lorlatinib. Again, these are cross-trial comparisons, so always fraught. But nevertheless, when we look at 5-year PFS and 4-year PFS, lorlatinib certainly appears superior to alectinib and brigatinib. And we see major improvements in CNS control, as we've seen for alectinib in the adjuvant population. We're certainly seeing that with lorlatinib in the advanced recurrent and metastatic setting. The 5-year intracranial PFS, 92% overall, 96% in those without baseline brain mets. With the other drugs, particularly with crizotinib, you could expect brain mets in the vast majority of patients within 2-3 years, and that's shown in the control arm, only 20% free from progression in the brain at 5 years on criz. Finally, however, it's the toxicity. We would wholeheartedly embrace lorlatinib as the standard in everyone were it not for the toxicity. We see elevations in cholesterol and triglyceride, usually pretty early on, within the first few weeks. It's ubiquitous, grade 3, and about 20-21%. Virtually all my patients on lorlatinib are on statins. We start seeing neurologic effects, changes in mood, peripheral neuropathy, and 20-40%, problems with processing and thinking. I'd say about 75% of my lorlatinib patients are either on antidepressants or antipsychotics or anxiolytics to control some of these symptoms. Peripheral edema, weight gain, again, quite common and very bothersome. The edema, we can sort of keep it under control, but we can't reverse it. Lymphedema therapy, diuretics, compression stockings don't really prevent this. So I'm a bit more nuanced when it comes to lorlatinib versus alectinib. Lorlatinib I'll certainly give to younger patients, those with widespread disease, symptomatic, certainly CNS involvement. An older patient with comorbidities and very limited disease burden who's relatively asymptomatic from the tumor, alectinib is my drug of choice. But I'm an outlier in that regard. So the conclusions for ALK. Again, 3 to 8% of all non-squamous, younger patients, minimal or no smoking history, a high propensity for CNS progression. Big debate, alectinib versus lorlatinib. The latter certainly seems to have better progression-free survival and potentially more CNS penetrance, but heightened toxicity. And salvage therapy really depends on what the patients previously received. So if they've had alectinib, brigatinib, they go on to lorlatinib or the newest drug, nadalcanib, which is not yet FDA approved but available on expanded access. The final common pathway really for all of our patients with any sort of oncogenic driver remains chemotherapy, PEM-carbo with or without bevacizumab. And we've seen a clear role for alectinib now in the adjuvant setting.
Could I say you're maybe an outlier in many regards? Just kidding. Just kidding. I'm just kind of curious, Sunil, have you used lorlatinib?
Yes.
No, Sunil.
Oh,
sorry, Luda.
To be honest, no.
So, Luda, what would you advise Sunil? I mean, it's got very impressive. You have a young patient, wants every possible benefit. What would you say to a patient and family who's about to begin lorlatinib?
So it's hard to argue with 60% of the patients still without progression at 5 years. I don't think alectinib will get there. I do something very similar to Corey's. If it's a young patient, then I think it's kind of a no-brainer. And there is also other two camps. So some people start with 75, just automatic dose reduction. I start with 100, but I'll tell the patient that very likely I'm going to be dose reducing. Patients are afraid to dose reduce because they think it's going to affect the efficacy. And we know from the CROWN data that dose reductions really do not affect the efficacy. And I am not seeing as much of CNS toxicity, maybe because my population is mainly geared to younger patient groups. And we started with 100 and we watch them. I see them very closely for the first 2 months. And if there is any CNS toxicity, I drop down. I would never consider lorlatinib in a patient with pre-existing depression, pre-existing suicidal ideations, and pre-existing bipolar disorder. So that's actually one of the questions I ask when I decide if I want to do lorlatinib or not. For my elderly patients, kind of the very elderly, I'm with Corey, I would do alectinib. Kind of mid-range, I would try lorlatinib, and then I have a low threshold of either dose reducing or moving to alectinib. And I have my cardiologist on my speed dial. So we actually have an oncocardiologist. We have a cardiologist who is interested in seeing patients like that. And so they help. My first choice is, of course, statins. But in many patients, statins do not work. So you have to go to PCSK9 inhibitors. And in our institution, it's limited to cardiology. So they help me with that.
But what do you say to the patient or maybe to the family to look for?
Very good question. It's actually a very good question you said, because patients usually not aware that they're having mood disturbances. So when I make the discussion, I do talk to the family saying, if you notice that there is more anger, there is less tolerance, and especially if it affects the family or the kids, then let me know right away and I'll dose reduce or I'll change. Very good point.
Ross Wan.
So, getting into Ross now. So, much smaller population, about 2% of our non-small cell. The original agents were crizotinib and entrectinib. These were phase 2 trials reported by Alice Shaw, first in the New England Journal and then later in Annals of Oncology. Response rates quite good, 70% or so. PFS, 19 months for crizotinib, 15.7 for entrectinib, with really a survival benefit compared to historic controls. Entrectinib had the added advantage of CNS penetrance, which crizotinib doesn't have. As we get to the evolution of ROS1 inhibitors over time, we see evolving specificity. The newer generation drugs having greater systemic activity, including CNS coverage, greater capacity to work after prior tyrosine kinase inhibitor exposure, and better coverage of resistance mutations. And this is clearly characterized by the two newer drugs that are FDA approved, repotrectinib and taletrectinib, and the one that we believe will get approved soon, zidesamtinib. They get increasingly unpronounceable as well. If we look at this bubble plot, the size of the studies is shown by the size of the bubble. On the x-axis, we have progression-free survival. On the y-axis, objective response, you can see the two newer drugs are clearly superior. Response rates for repo and taletrectinib 80 to 90% respectively, and median PFS of 3 to 4 years. Again, we're getting into ALK and EGFR territory here. The safety profiles are very different. For crizotinib, going back to the beginning, high incidence of edema and vision disorders. Usually the latter was readily reversible. For entrectinib and repotrectinib, again, the toxicities, peripheral neuropathy, dysgeusia, dizziness, some degree of weight gain. For the newest drug, taletrectinib, the neuro and toxicities and edema are less of an issue. We see more GI toxicities, more transaminitis and diarrhea. This is an update on repotrectinib. Again, they had two separate cohorts, TKI naive group and those who were previously treated. Fairly large phase 2 as we have overall survival now. So at 4 years in the TKI naive population, the survival rate is 56%. Again, quite promising, maybe not quite as good as ALK, but we're getting there. And for those who had previously exposed to TKIs, 36%. Again, many of these folks had prior platinum exposure. The data are not quite as mature for taletrectinib, but if you look at the TKI naive ROS1 population response rates, again, about 90%. Intracranial activity, as we've emphasized for the other agents, 66%. For those who've been previously treated, response rates dropped to about 80%. 50% intriguingly if they had no prior chemo. Time to response is rapid within a month and a half, and the efficacy intracranially is quite good. Fairly low toxicity rates. Most toxicities were grade 1 or 2. You see dysgeusia about 15% grade 1, 4% grade 2, and this becomes sort of a bothersome quality of life issue when all the other toxicities go away. Some degree of dizziness, very low rates of treatment discontinuation. The newest drug, AROS-1, studies zidesamtinib. This is a huge effort. It's got over 500 patients, all with advanced ROS1 positive non-small cells, whether other solid tumors that show ROS1 fusions. We have TKI naive groups, those exposed to just one and those exposed to two or more. For the previously treated group in the left upper panel, response rates of about 50%, and those who had one prior plus or minus chemotherapy. Note that the 18-month progression-free survival here is 68% with this newest agent compared to 40% for those who had any prior ROS1. And in the treatment TKI naive group, response rates are about 90%. On the waterfall plot, virtually everyone is responding. And again, we see intracranial responses. For toxicity, fairly low rates of grade 3. We see some transaminitis and weight gain at about 11%, peripheral edema at about 20%, but mostly grade 1 or 2, and very low rates of either dose reduction or dose discontinuation for toxicities. What do we do when the patients have progression? Well, again, I emphasize the need for biopsy, certainly for liquid biopsies and tissue biopsies if you can do it, because increasingly with better selection against ROS1 and against the mutations, we're seeing off-target or mixed resistance. We're seeing transformation now. We're seeing some degree of bypass pathways. Mutation coverage does correlate with activity. So these are TKI pre-treated patients. Again, response rates about 50% or so with taletrectinib, the newer drug zidesamtinib. For the ROS1 gateway G2032 resistance mutation, zidesamtinib does relatively better with a response rate of 83%. And again, the data for prior TKI exposed, 2 or more prior TKIs plus or minus chemo with this new agent, again, not yet FDA approved, but probably soon, 38%. Prior repo, response rates 47%, prior taletrectinib 43%. So the only drug for which we have data now with the prior exposure to the two agents that we use. Finally, the strategies for off-target or polyclonal resistance are shown here. Chemo is still our standard. Once you've exhausted TKIs, response rates with chemo can approach 80%, PFS of 2 years. IOs add very little to this. The numbers look no better, and certainly immunotherapy alone seems to be insufficient. And certainly a role for investigational approaches and perhaps combinations of TKIs with chemo. So the conclusions for ROS1 are virtually identical to ALK. The same populations demographically tend to be younger, never smokers, aggressive clinical outcomes, high propensity for CNS involvement. but the percentage is much lower. It's only about 1.5 to 2% compared to up to 8% for ALK, and the drugs are different. Crizotinib and entrectinib are of historic interest. Taletrectinib, I think, has eclipsed repo. Luda may or may not agree with me. 80 to 90% response rates in treatment-naive patients, CNS penetrance, and median progression-free survival, never mind overall survival, median PFS now of 3 to 4 years, and the newest drug may even be superior.
Quick question from the audience. Luda, someone has a patient with T2 multi-station station N2 adenocarcinoma of the lung, 56-year-old woman, treated with chemo-RT. Would you use ROS1? This patient has ROS1 mutation. Durva or ROS1? If so, which one?
Yeah, this is hard. So first of all, very tempting. No, not FDA approved, so it's going to be hard for you to get it approved. I tend not to do that unless you have a study, but certainly if it's hard. I'm on the point right now, I wouldn't do that, but you're probably going to find plenty of physicians who will just do it off-label.
I won't ask you what you would do if it was a medical oncologist who was the patient, but anyhow, let's just move on. Thank you so much.
Yeah.